This is primarily a talk directed towards GPs working in the primary care sector, but really, I know we've got a fairly diverse crowd today. I think really this information is valuable for anyone working with patients with substance dependency problems, where we do see a very high level of benzodiazepine prescribing. If you look at prescribing benzodiazepines, one way of staying out of trouble is this way. And some practices do take this approach. Conversely, you may see articles like this that Judith Rankin sent to me the other day from Psychiatry Update. But probably for the rest of us, we know that benzodiazepines are useful medicines in primary care. They help immensely with distress. Patients expect us to prescribe them, but to prescribe them safely. And colleagues and government authorities in general expect us to prescribe them safely as well. So the focus of this talk really is around safety and benzodiazepines in primary care. They were discovered in the mid-50s. They came in heralded as wonder drugs because they replaced a very dangerous group of drugs, the barbiturates. They were the sedatives and hypnotics were available prior to benzodiazepines, and in terms of safety, we knew that there were a significant improvement because of the respiratory depression that was associated with barbiturates. The first benzo was Librium, chlordiazepine epoxide, and shortly afterwards we got good old diazepam, Valium. As I say, they were greeted with great joy because they certainly were a useful therapeutic agent. And if anyone's taking notes, I've got handouts of this talk, and you're more than welcome to have them and use them, and hopefully there'll be a bit of a practical guide for people as well. In the 70s, they became one of the most frequently prescribed medications, and basically, it took about 15 years for people to work out how they actually worked, and they basically affect GABA levels in the central nervous system. By about the 80s, we were starting to sort of question benzodiazepines, and you know, they were useful drugs, but they were problematic drugs as well, and we were seeing misuse, we were seeing dependence, and medical leaders were starting to become concerned about the use of benzodiazepines. And along the way, we've actually seen some rescheduling of benzodiazepines. Recently, we had alprazolam rescheduled to Schedule 8. And earlier on, we had the removal of temazepam gel caps, which were being injected by a lot of injecting drug users because they actually had a liquid inside. And we were seeing IDUs actually losing fingers and even limbs from injecting the temazepam liquid. Their mode of action is to basically enhance GABA in the central nervous system, gamma-aminobutyric acid. They bind to the GABA receptor and increase the binding of GABA. The binding opens up the chloride ion channels and allows an influx of chloride ions into the cells, and this basically leads to hyperpolarization of the cell membrane, which in turn leads to an increase in the firing threshold of that neuron and an inhibition of the action potential. They lower the level of GABA required to have the same inhibitory effect and prolong the binding of GABA to the receptor. So they're basically inhibitory drugs in the central nervous system. You know, what a street user would call a downer, as opposed to an upper. If you want to avoid problems, there are some very simple caveats, and you know, we put these out all the time, but we also realize in primary care there is immense pressure to prescribe these types of medications. So this is why the talk is not only about staying out of trouble, but about getting out of trouble. Ideally, you shouldn't prescribe benzodiazepines to patients you don't know. You shouldn't prescribe benzodiazepines to polydrug users, and certainly if you're concerned about a polysubstance user who is benzodiazepine dependent or a benzodiazepine user, you're more than welcome to contact our service and ask for some help, guidelines, strategies that we'll talk about later on. Ideally, you should avoid prescribing benzodiazepines to patients on an opioid treatment program. However, when you look at most opioid treatment programs, about 50% of patients are on benzodiazepines. And this, I think, reflects the tension and pressure there is in primary care to try and reduce distress. That's often why we're all in primary care. And at the same time, it also represents, I guess, the manipulativeness that some drug-seeking patients may do to get that sort of medication. And, ideally, don't prescribe benzodiazepines on the long term. As opposed to our psychiatric colleague that I put the article up about, I really don't believe that benzodiazepines have got much of a long-term role with many patients at all. If in doubt, or if you have a patient who you think might have a therapeutic dependency, there is the doctor shopping line. It's useful, but it's not foolproof. One of the problems with the Medicare doctor shopping line is that it only documents medications that are prescribed under the pharmaceutical benefit screen. So if you've got benzos being prescribed on a private script, they won't be picked up by the doctor shopping line. In an ideal world, we would have real-time monitoring of benzodiazepine prescriptions available to GPs, just as we would for opioids. And certainly there is a project at this point in time to try and get that happening around prescription opioids, and it would be good if in the medium to long term we saw benzodiazepines also lumped into that group. When you look at the problems associated with benzos, we certainly see misuse, we certainly see dependency. We often see benzos being used in a background of polysubstance misuse or dependency. Particularly methamphetamine, of course, is a very topical drug at this point in time, and a lot of patients will use benzodiazepines for the come down after using methamphetamine. There's the risk of overdose, particularly in the presence of opioids, and we all remember the loss of Heath Ledger, and that was just a combination of oxycodone and alprazolam. We know that benzos have cognitive effects. They affect attention and memory. If patients are taking high doses, it'll affect attention and memory in everyone, but we particularly see those effects on the elderly. You may see patients on benzodiazepines who are having untreated and unrecognised withdrawal, and that may be being mistaken for panic attacks or anxiety disorders and the such like. And very often benzos will cover over underlying anxiety disorders while actually not impacting on them in terms of getting therapeutic resolution. And we see certainly a lot of patients doing doctor shopping behaviours around benzos. And that's often at cost to the patient. It may be a cost to GPs who get into trouble for prescribing, and of course it may be a cost to the community in terms of behaviour, and it may be a cost to governments in terms of the cost of those medications and the consultations associated with it. When you look at dependence, it's really important to try and identify those patients who are truly benzodiazepine dependent. So your IDC-10 criteria include, a strong desire, over the previous 12 months, a strong desire or compulsion to take the substance, difficulties in controlling the substance use, a physiological withdrawal state, or taking the drug to avoid withdrawal, evidence of tolerance, in other words, an increased dose to get the same effect, progressive neglect of alternative pleasures and interests because of the psychoactive substance use, persisting substance use in spite of it causing health and other problems. We generally, when we're assessing benzodiazepines in addiction medicine, tend to look at patterns of use and use a sort of cut-off point around about 40 or 50 milligrams of diazepam equivalents per day. Low dose use is 40 milligrams or less, and high dose use is greater than 40 milligrams. When you look at low dose users, they tend to be patients who have underlying anxiety disorders. They may have problems with insomnia, psychiatric disorders, possibly epilepsy. They tend to be an older age group, females greater than males, and they may require therapeutic alternatives rather than just pure withdrawal. In other words, you may be dealing with someone who's both dependent and got an underlying anxiety disorder as well. And generally, with the low-dose users, they can be managed quite well in a sort of ambulatory setting. High-dose users, generally they'll be using 40 milligrams diazepam equivalents or more per day. They'll often be escalating the dose. They may well be binging, and we might talk a bit about that later on, where you get someone come in and say, I took 50 Valium yesterday, and you go, well, my God, what do we do then? Do we prescribe 49 today? They may inject benzodiazepines, although, as I mentioned earlier on, one of the good harm reductions we saw in I think it was the noughties. Alex, when did we get rid of gel caps?
It was during Wooldridge's term, so that was around about 95, 96.
95, 96. Time passes when you're having fun. But at that point in time, we were seeing a lot of people actually sucking the liquid out of these temazepam gel caps, injecting them, and I had OTP patients who were missing fingers from getting an ischemic response. And with the high dose users, you very often see polysubstance misuse. So it tends to be someone who's using a variety of different substances. They tend to be younger. They've often got significant lifestyle and psychosocial problems as well. When you look at high-dose use, a high-dose user, if they've got dependency, may well require inpatient stabilisation. That's one of the things that we do at Riverlands quite often. I mentioned, the binge pattern of use, and I think that's important because, you'll see a lot of opioid-dependent folk might use benzos in between to get them through till the next time they can actually access an opioid. But we tend to find that those particular folk aren't that degree of tolerance compared with someone who's built up a large heavy dosage over a significant period of time. So it's often useful, we find certainly in our service, to actually test people's tolerance when they come in, and one of the ways we might do that is actually run them up for diazepam 10 milligrams every couple of hours or more, and try and sort of weave between, I guess, agitation and withdrawal and sedation and falling into their soup. And we might do that for 48 hours to get a guide to what someone's level of tolerance is if their use is, fairly undocumented and often has a binge pattern. And a lot of the time we find those particular patients don't have that level of dependency, which is quite good. It's good news. High-dose users often prefer rapid onset and more potent benzodiazepines, and I'll talk a little about that in a minute. And as I mentioned, you may see variation in the level of neuroadaptation due to binge pattern of using. Get down to the nitty-gritty. There are various different types of benzos, and I'll get my laser pointer out now because this is what I want people to have a little think about. When we look at benzos, we look at a number of things around them, and this is diazepam, and basically what we try and look at is the peak concentration, the rapidity of onset, because that's quite significant in terms of both misuse and dependency. We tend to look at the elimination half-life as well, because again that is significant in the management of benzodiazepines. And we tend to convert into diazepam equivalents. So, diazepam 5 milligrams is equivalent of diazepam 5 milligrams. Look at alprazolam, and one of the reasons that in addiction medicine we didn't particularly like it was that it's got a fairly rapid onset. It's got a potentially short elimination half-life if it's not taken all the time. The variation is really depending on whether someone's on that on a regular basis or whether they're taking it intermittently. And it's got quite a high potency. I mean, basically half a milligram of alprazolam is the equivalent of 5 milligrams of diazepam. So you can imagine if someone's on alprazolam 2 milligrams twice a day, well, they're on the equivalent of 40 milligrams of diazepam a day, which is a fairly high dose. And while a lot of doctors might say, well, I'll prescribe alprazolam 2 milligrams BD, no worries. If you said to them, would you prescribe 40 milligrams of diazepam a day, they'd say, no way. Clonazepam, which I'll talk a little bit about in relation to withdrawal management, has got a much shallower gradient for peak onset and a much greater elimination half-life. Lorazepam, Ativan, sort of in between. Nitrazepam, an old-fashioned sedative hypnotic, again, fairly slow onset, fairly long elimination half-life, equipotent really to diazepam. But if you look at some of the sedative hypnotics like oxazepam, comes on fairly slowly, but it's got quite a quick elimination half-life. Look at temazepam, comes on pretty quickly, it's got quite a short elimination half-life. You look at Stilnox, it comes on pretty fast and is eliminated pretty fast. And basically these are your equivalent doses when you're trying to calculate sort of, what equivalent someone is on benzodiazepine-wise. Bad benzos. Basically, when we're looking at benzos, certainly in addiction medicine, we know that certain benzos seem to be more problematic than others. As I mentioned, rapid onset. The gradient with which a drug enters the central nervous system will have an effect on that cascade of dopamine release that happens as a secondary process. So things like temazepam, zolpidem and alprazolam, we're concerned about the rapidity of their onset. And zolpidem's interesting because, you look at the Australian swimming team bonding, it was basically a substance, benzo that was being misused. Short half-life, again, concerns us because, rapid onset and rapid elimination means that you've got a patient that's going up and down in terms of their benzo effect. High potency is something else that concerns us. 2 milligrams of clonazepam is the equivalent of 20 milligrams of diazepam. So again, the potent benzos are often those that are sought out by substance misusers or doctor shoppers, as well as the short half-life ones or the rapid onset ones, and alprazolam falls in there. And the amount you can get on the PBS may be a factor. Clonazepam, although it's a good benzo in terms of its slow onset and long elimination half-life, in terms of its availability, you can get 200 milligram tablets on one script on the PBS. So, if you're basically getting benzos to misuse or to sell on, your profit margin can be pretty good with clonazepam. And most of these drugs have got street names. Clonazepam's known as Rivies, Xanax is known as Xannies, Valium's known as Vals. Certainly we do see clonazepam misuse in spite of the fact that profile-wise it's probably a safer benzo in terms of dependency and misuse. When you look at stopping benzos, again, when I was a med student in the 70s, there was a huge debate about this, about whether you saw benzodependency or not. The various reps from Roche and people like that would say, no, you never see it, you just see rebound phenomena and then that settles down. But really, when you look at stopping benzos, I think you can see three things happening. You can certainly see a rebound phenomena. You can certainly see the re-emergence of underlying anxiety disorders. If you've just papered over the cracks and you take over the paper, the cracks are still there. So you'll certainly see in patients with anxiety disorders, panic disorders, when they stop benzos, those symptoms will re-emerge. And you certainly do see a withdrawal syndrome in some patients. Rebound phenomena are basically purely that. They're a rebound from the use, a bit like, if you've had too much alcohol the day before, you've got raised GABA levels when you're using alcohol. decreased glutamate levels. When you wake up the next day and feeling rather seedy, you've got low GABA levels and increased glutamate levels. And so you'll see the same thing with benzos. You'll see after a few weeks or a few days of normal use, generally those sort of rebound symptoms will only last a few days. The onset will be related to the half-life of the drug. And very often, you may see a bit of anxiety and insomnia, but it may, of course, be, symptom re-emergence as well. And generally with rebound phenomena in primary care, all you've really got to do is reassure the patient that, this will settle down in a few days. If you look at symptom re-emergent, it's often difficult to distinguish those from rebound phenomena. If you look at patients with anxiety who've been put on benzos, you'll see, basically re-emergent symptoms in 50-60%. And those patients with significant anxiety disorders like panic disorder, you'll actually see, re-emergence in virtually all of them. And I guess the treatment for symptom re-emergence is to actually treat the underlying condition rather than treating the symptoms. So, the trick is to avoid returning to benzodiazepine use. And certainly clinical psychologists tell us that in terms of new learning, because of the issues with memory and attention, it's really hard to do CBT on patients who've got, a lot of benzos on board. CBT is the evidence base for anxiety disorders. We know that clinical psychologists can get good responses with CBT and appropriate medication that I'll talk about in a little while. If you look at withdrawal symptoms, syndromes, they can occur after about 6 weeks even on a low dose. So, certainly you'll see, fairly rapid neuroadaptation to these medications. They may be short to long acting in terms of the duration, may last a week to 6 weeks. And they can certainly, it lasts 6 to 12 months in heavy users who've been using for a long period of time. Basically somewhere between 15 and 50%, and you can see that, this is kind of cloudy, between an eighth and half, who receive more than 6 weeks on benzos will have some sort of a withdrawal syndrome. And the symptoms of withdrawal syndromes from benzodiazepines can vary considerably, and they can be quite subtle, often hard to pick up. And again, if you're thinking about, you've also got rebound phenomena, you've also got symptom re-emergence, and you've got withdrawal as well. It's often hard to tease out exactly what you're dealing with. Luckily, the approach is fairly similar. Benzo withdrawal is often very subjective. In other words, there's a lot of sort of internal stuff rather than external stuff. Patients often describe it as very distressing. They often say, they're worried they're going crazy. They may even be, a little bit paranoid. They find it hard to actually disclose the symptoms to patients at times. There may be very few sort of hard physical observable signs associated with benzodiazepine withdrawal. And as I mentioned, patients are often, they feel they're going out of their minds and are often quite concerned. And the severity of withdrawal generally is related to the dose, the diazepam equivalents that they're taking. And that's, one of the reasons why in addiction medicine we're pretty concerned about alprazolam because of its potency and the group of patients that receive it. Most common sort of symptoms of withdrawal tend to be anxiety, insomnia, restlessness, agitation, poor concentration, difficulty with memory, and depressions. And a lot of patients coming off benzos will complain of poor sleep and anxiety and restlessness. And you may often see that as an observable physical sign at times. The patient may be, actually physically restless. In some patients, you'll see increased muscle tension. Patients will often complain of aches and pains, tension headaches, those sorts of things. myalgia, and in severe withdrawal you can actually see sort of, tremor, twitching, and so forth. Less common symptoms include psychological symptoms, maybe sleep disturbance associated with nightmares. The patient may become quite agoraphobic and quite fearful of going out. They may feel this feeling of dissociation, and that's often part of that. I'm going out of my mind, I don't feel myself, I feel quite depersonalised. And they may experience panic attacks as well. And again, whether that's withdrawal or symptom re-emergence, at times I don't think we're really sure. Somatic symptoms might include nausea, vomiting, anorexia, weight loss and diarrhea. Some patients in severe withdrawal will have sweating and palpitations. They may have tremor, paresthesia, muscle aches and pains, headache, lethargy. They may be ataxic, they may have blurred vision, and very occasionally you may see pyrexia and even menstrual changes in some patients. This is obviously at the high end of the scale of things. Uncommon symptoms, but symptoms we sometimes see, particularly in the elderly, are delusions, paranoia and hallucinations. And many, many years ago when I worked out at Nimbin Hospital, we used to be, we had an excess of beds, and we were actually a slow stream rehabilitation unit for patients who were awaiting nursing home placement. So often someone had been to hospital in Lismore, they weren't able to go home, they'd come to us for aftercare prior to being placed in a nursing home. And I actually remember having a patient who presented to us for slow stream rehab or nursing home care who had dementia, or was supposed to have dementia, and we actually took a significant history and looked at her benzo use. She was actually in benzo withdrawal, and we started her on some diazepam again, and her dementia disappeared. It was quite amazing. One of the most phenomenal things I've ever seen, and it was good save because she actually went home. You may see seizures, tinnitus and delirium, and that's particularly in the elderly, and that's often a good talking point because, again, in primary care you'll often get someone lob in you've never met before. They'll say, I'm on Rivotril or Xanax or something like that, I've run out, I've just had a fit. Seizures actually are really rare with benzodiazepine withdrawal. You don't see them that often. They tend to be more common in the elderly, and often when someone says they've had a seizure from benzo withdrawal, it's really useful to actually ask, well, what do you mean by a seizure? Because they'll often describe a panic attack, but they'll say, it's a fit. And as I say, seizures aren't as common as some patients would like us to think. When you look at benzo withdrawal, basically your short actors tend to cause more problems because you get more rapid onset of symptoms. Long-acting benzos are easier to withdraw patients off, and low-dose users may experience minimal symptoms, so they may actually be able to just stop and have symptomatic relief. Little chart, bit busy I'm afraid, on benzo withdrawal. These are in the handout, so it's just a matter of pointing out that short-acting benzos tend to peak around about sort of 5 to 7 days, whereas you may see withdrawal from longer-acting benzos up to sort of 3 weeks after cessation. When you look at key management, it's important to average the daily dose, look at the half-life of the drug, look at the duration of use, look at the individual physical and mental characteristics of the patient, and the rapidity of the withdrawal. So, that little table of diazepam equivalents becomes useful when you're sort of assessing how you're going to manage withdrawal. Abrupt withdrawal results in the most severe symptoms. Well, who would have thought that? Gradual reduction results in less severe but more prolonged symptoms. Often when you're working with patients with benzo withdrawal, it's difficult to get them started. They're often very fearful. They've often run out of the medication before and had significant withdrawal, so they need a lot of reassurance. But once you get them started, they often go quite well. And some find just that last little bit of benzo reduction quite difficult as well. When you look at withdrawal management, it's important to establish a good therapeutic relationship. Stabilise them initially on a long-acting benzo. We tend to use diazepam in Australia because of its long elimination half-life, but probably in an ideal world you'd actually probably use clonazepam, and I know in the UK it's used for benzodiazepine withdrawal because it's got this nice long half-life. It basically produces a good steady state, and then you can just sort of taper the dose down slowly. Reduce by a proportion of the dose per day, and be flexible with the reduction. There's variation in the symptoms, and if you've got a patient where you've established a good therapeutic relationship and a high degree of trust, then I think you need to reward them by reciprocating with that trust and listening to what they're saying and working at their pace. We do have benzo withdrawal scales. I must say I don't use them that much. There's little research on their validity. It's less predictable than alcohol withdrawal scales that have got a good evidence base, and clinical judgment and own observations are probably important when you're managing patients with benzo withdrawal as much as withdrawal scale. Ambulatory withdrawal suitable for low dose users. People who are initially attempting to withdraw, have no significant psychiatric disorders, have an appropriate home environment, have no compliance issues, and you may use that for high dose users after they've been stabilised and withdrawn in an inpatient unit. If you look at inpatient withdrawal, we often do that for high-dose users. As I mentioned earlier on, we'll actually often say, well, let's test what this patient's tolerance is over 48 hours to benzos before we can work out a plan, because you may have a binge pattern where someone's not that neuroadapted, even though their history suggests they are. It's better for patients, obviously, who've got polysubstance misuse or dependency or an inappropriate home environment. And for aged patients who've got concurrent medical conditions as well, inpatient withdrawal may be more suitable. It could be a residential setting or it could be a hospital setting. As I mentioned, withdrawal seizures are rare from low doses. They most likely occur on high dose, high efficacy, short half-life medications such as alprazolam. And those of us in addiction medicine did sort of heave a sigh of relief when alprazolam went Schedule 8. As I mentioned, they can occur about 24 hours after ceasing short-acting, short half-life benzodiazepines, and up to 7 to 14 days after long-acting, long half-life benzodiazepines. They're more likely in the presence of alcohol abuse, old age, and other drugs that may affect seizure threshold as well. If you've got someone with an underlying anxiety disorder, it's really great if you can engage them in some form of CBT before you start withdrawal. Also, really, when you look at what medications help with anxiety disorders, SSRIs, SNRIs really, I think, are more helpful in anxiety disorders than often depression. And sometimes a sedative tricyclic antidepressant may be useful. And if you can stabilise them for a couple of weeks before you start to withdraw them, you'll get better outcomes. So the key steps really are stabilising the patient, switching to a long-acting benzodiazepine with inpatient stabilisation if needed. As I mentioned, if they're already on clonazepam, I'd keep them on that. The trick is to reduce the dose between 15-20%, so between sort of an eighth and a fifth. And reduce them about every 1 to 2 weeks. The important thing with patients on benzos is to tell them to take the doses on a regular basis, because often these patients have got really good intentions. I say, I took nothing yesterday, but then they have a panic attack and take heaps. So, it really is explaining that you're stabilising and slowly tapering down rather than treating any underlying cause. And that's where I think your good therapeutic relationship is important. Reduce at an agreed rate and supply with regular monitoring and review. Your treatment interventions for anxiety are really important. Stabilisation, as I mentioned, on SSRI or SNRI before commencing reduction is helpful. If you've got someone with poor compliance, they can pick up at a pharmacy on a daily basis. Community pharmacies are more than happy to help with these sorts of situations. And in an ideal world, you'll follow up your patient after withdrawal for 1 to 3 months, making sure that they're plugged into the appropriate treatments for their underlying anxiety disorders. Patient diaries are useful in helping patients with anxiety and reductions, and also their actual consumption and symptom severity. Reduction should be tapered towards the severity of those symptoms because there's a lot of variation, and it's better to reduce a little bit more slowly than have famines and then feasts. In other words, a reduction than a blowout. And it's important to remember that patients are individuals. They bring their underlying psyche with them, and they vary considerably in circumstances and time and ability to reduce. I think the important thing is to make sure that you're moving smoothly but effectively in the right direction. This is an example of a low-dose benzodiazepine withdrawal where someone's on diazepam 15 milligrams a day, and as you can see, you're tapering them down over about sort of a 10-week period. So it's not quick, and that's probably an important thing to explain to patients is we can help you come off these medications, but it's not going to be quick. But it also needs not to be slow either. High-dose withdrawal generally will stabilise patients in a residential setting. We might have someone who's on, say, the equivalent of 80 milligrams of diazepam a day. In our inpatient unit over 1 to 2 weeks, we might bring them down to somewhere between 40 milligrams a day, and then get them back into a primary care setting where they're reducing more slowly. Dose stabilisation, generally most patients will stabilise on 80 milligrams or less, and I mentioned, as I say, the sort of bingers, we'll often find that, when we actually test their tolerance, they're quite comfy on 40 milligrams of diazepam in spite of giving history of consuming heaps and heaps of benzos on intermittent occasions. In the inpatient unit, you might reduce the dose by 10% a day. Other risk factors may warrant a higher stabilisation dose, so a history of epilepsy or previous withdrawal fits. You need to avoid excessive sedation. As I say to patients, we're going to keep you comfy, but we're not going to have you falling asleep in your soup. And you should be looking out for signs of other drug withdrawal as well, because often there's a pattern of polysubstance dependency or misuse there as well. Rapid inpatient reduction is only really helpful in nursing or medical supervision settings. Target of a daily dose of 40 milligrams of diazepam, daily monitoring over 5 to 10 days for late withdrawal, and only reduce off of as an inpatient if safety and compliance are issues. So we may bring people down a bit more quickly because really this is the only way you can manage them, and the whole idea is to get them off the benzos without them having a withdrawal fit. If you can organise ambulatory withdrawal, and that's where working with primary care is so important for us who work in addiction medicine, then that's the ideal situation with the caveats that I've mentioned before. That's an example of a high-dose withdrawal that we might do at Riverlands, where someone might start on 80 milligrams a day, and over 12 days we'll bring them down to 10 milligrams and then stop. And generally with that patient, they won't have a withdrawal fit. They may have rebound symptoms, they may have anxiety, but because of their pattern of polysubstance misuse, their lack of compliance with the treatment plan, we're going to have to bring them off, and the trick is to try and bring them off at least reasonably safely. Adjunctive medications. We may use in our inpatient unit at times some of the atypical antipsychotics. As I mentioned earlier on, if a drug's got a nickname on the street, then it's a drug of misuse. If a drug's got a nickname by nursing staff, then it's probably a useful therapeutic agent. Our nurses call olanzapine vitamin O, and they find it incredibly useful for agitation associated with benzo withdrawal. I think it should only be used in the short term, and ideally in an inpatient unit setting, and we don't discharge patients on olanzapine or other atypical antipsychotics. Propranolol may be useful for somatic symptoms such as tremor. Clonidine has been shown to be useful in some patients with panic attacks, and sedative tricyclic antidepressants, SSRIs or SNRIs may help with anxiety and sleep. We also sometimes use sedating non-benzodiazepines such as antihistamines, so promethazine or other antihistamines may be helpful to help with sleep. So in summary, Benzos are incredibly useful drugs in primary care, and I think that, if you work in primary care, benzos really do help patients with distress in the short term. I think it's important if you're prescribing benzos to talk to patients about the benefits and the risks. And one of the things we find with patients who are benzodependent when they come to us is that, one of their complaints often is, nobody warned me about this and now I'm going through hell. SSRIs, SNRIs are incredibly useful for anxiety, as is CBT. It's useful to have a practice policy about safe prescribing, and I think the Royal College of General Practitioners just released a clinical governance paper on prescribing psychotropic drugs in primary care. I was looking at their website yesterday. Universal precautions for ambulatory withdrawal. By that I mean basically one prescriber and one pharmacy. So one prescriber writing the script and one pharmacy dispensing the medication. And as I mentioned earlier on, if there's problems with compliance, you can actually get patients to pick up daily. Pharmacists are more than happy to do that. And use your referral network, which includes us at Riverlands if you're experiencing problems around benzodiazepines. So what do you do if you get into trouble? We basically have intake for the district at Riverlands, and that's the number there. We also, because we come from a primary care backing, most of us who work at Riverlands, the medical officers there, we kind of have an affection for primary care. So we actually provide a callback service for GPs where if you give us a ring and you're struggling with a patient, we'll usually try and get back to you within an hour or so, to talk about putting together a treatment plan for that patient. And if we're not available, because we basically are only available from 7 a.m. to 11 p.m., there is always the Drug and Alcohol Specialist Advisory Service that has a 1-800 number that you can call 24 hours a day, 7 days a week. Those are some references. One of the things that I think is good for you guys to know is that, on the New South Wales Health website, there are actually withdrawal guidelines available. You can download them, that's the link there. The other reference for this paper is a very good review around benzos from a few years ago by Malcolm Lader, Benzodiazepines Revisited, Will We Ever Learn? Thank you for your attention.